as some COVID questions.
Okay.
One of the questions I got was, what sort of follow-up monitoring might you do for a third trimester patient who had COVID? So this is from SMFM's latest clinical guidance, because SMFM continually updates it. And I believe their last update was sometime in late March, perhaps. Don't remember exactly.
Yeah, that sounds right.
So basically what the thought is, and this is not definitive, but what the thoughts are that infection in the second trimester tends to be more associated with an increased risk of adverse obstetric outcomes, whereas infection in the third trimester could be more related to adverse neonatal outcomes. So that usually means you're infected in the third trimester, and that would require a delivery, which may be preterm, and that could cause more of the adverse neonatal outcomes. Whereas infection in the second trimester, you're more likely to stay pregnant. And that's where you hear about risk of the preeclampsia-like syndrome and stillbirth,
right.
Just to name a couple. There's no formal recommendations, but what the SMFM is saying is this. If you have had first trimester or periconception, meaning right around the time you conceived, COVID infection of any severity, a detailed anatomy ultrasound at the 18 to 22 week mark should be considered. That is different than a basic anatomy scan. A basic anatomy scan is typically done in low risk patients, whereas a detailed anatomy scan might be done because someone's advanced maternal age, they have medication exposure, anything that would require a more detailed assessment of the fetal anatomy. So they're suggesting that should be considered if someone had COVID infection periconceptionally or in the first trimester. Growth assessments, meaning starting serial growth scans, they can also be considered depending on the timing, meaning when the COVID infection occurred, and the severity of the disease. And also if there are other adverse outcomes, adverse or maternal risk factors, for example.
Right.
A patient that's diabetic and chronic hypertensive and they had COVID infection. Now, if you're diabetic or hypertensive or both, you're going to be getting serial ultrasounds anyway for growth. But obviously adding on COVID to that infection at some time during the pregnancy is going to further endorse that. But there's no recommendation on when to start, how often to do them. Various practices are doing various things. When you talk about the risk of stillbirth, and we're getting more and more information about there being a possible and likely association with the increased risk of stillbirth, there's no recommendations on when to start fetal surveillance. And what fetal surveillance typically means is like getting non-stress tests or BPPs or things like that to assess fetal well-being. So what SMFM is recommending is that those tests be done for other or routine obstetric indications, like you've had diabetes, hypertension, although I know some practices are implementing fetal testing or fetal surveillance for COVID, and that's within their right to do so. As far as delivery, having COVID is for example, you had it at 28 weeks. That doesn't mean you have to deliver at 37 weeks. That doesn't mean you have to deliver at 39 weeks. The timing of delivery might be changed or be more pressed if you get COVID infection later in pregnancy. Then that might require that you be delivered early. But if you recover earlier in pregnancy, then you should be delivered for what we call routine obstetric indications, not just because you had a COVID infection that you've already recovered from. Now, the last thing I want to address is, I get this question a lot. I'm getting put on low-dose aspirin and heparin injections. There is no recommendation for that. But I think the reason why docs are doing it is because this association with COVID infection and the preeclampsia-like syndrome. Sorry, let me take a drink.
Okay.
And I get that because you hear the word preeclampsia. And what do we do for people at increased risk for preeclampsia? We recommend low-dose aspirin. The caveat is this. The mechanism for the effect of preeclampsia on the placenta is not the same as the mechanism of the effect of COVID on the placenta. They might cause the same end result, but the mechanism is different. So we have no evidence that low-dose aspirin, and definitely not heparin injections or Lovenox injections, are going to improve or decrease the risk of the preeclampsia-like syndrome with COVID that may develop. So that's why that's not recommended. Like I said, although it's a preeclampsia-like syndrome, it's called a preeclampsia-like syndrome because the mechanism is different and its effects on the placenta are different. So in my practice, we do not do, go ahead.
And I don't think we're recommending it, postpartum either, even if they're currently infected at the time of delivery.
So the only time to get blood thinners or Lovenox or heparin is when if a pregnant patient is acutely affected and hospitalized.
Yes.
Once they're well enough to go home, there's no recommendation to continue any kind of anticoagulation. Okay. And then as far as the booster, we don't have the ACIP met on April 6th. I thought they were going to put out a recommendation. They did not. Right now, it's only recommended the second booster for those over 50, especially those with underlying medical conditions. Hopefully it will come out soon. So I go by what the ACIP recommends. So when the ACIP recommends that second booster in pregnant individuals, I will endorse that. So I get that question a lot as well. Again, it's up to you and your provider, what you want to do. But me personally, I go by what the ACIP says. What about you?
Yeah, same thing. I mean, I have a lot of patients that are still asking me, when can I get my second booster? Is it out yet? Am I available? You know, should I get it? And I just say we haven't heard yet, but we're waiting, basically.
Yeah. With the COVID vaccine, I think we should go by what ACIP says, because they're working night and day to put these recommendations out. And my practice is goes by what the CDC and ACIP recommend. Okay,